have Dr. Hines presenting our first case, our first rounds. So Dan is originally from Moncton, New Brunswick. He did his BSc at UNB in Biology and Leadership Studies. And this was followed by a master's in marine genetics at UPEI. And then he came back and did his MD at DNNB. He did his CCFP at Dalhousie at the Moncton campus. And this was followed by his CCFPEM at Queen's. And we're happy to have both him and his wife, Dr. Erin Sloan-White, with us as members of our department, enjoying all the beautiful parts of New Brunswick. And they're now the proud parents of beautiful daughter Ella. And we're just happy to have all you here in New Brunswick with us. Without further ado, Dan, I'll let you talk about how frailty impacts patients in the emergency department.
Thanks, Chris. Thanks everyone for tuning in this morning. Yeah, I thought over the years of medical training, I sort of got more and more interested in frailty and its syndrome, and more why we should be aware of it, how it impacts us in the emergency department, and things we can do or at least talk to patients about. So we'll kind of get into it. If there's questions along the way, feel free to interrupt, write in the chat, speak up. So to get started, I have no financial disclosures or really any other conflicts of interest with respect to frailty in the elderly, aside from I think it's an interesting topic and one that we should really consider and be aware of. Today, what I think I'd like to do is try and define frailty for everyone so that we can at least all get on the same page of what we're talking about. Describe why frailty is relevant to us in emergency medicine and why in our emergency medicine patients. And how does it impact patients presented to the ED and thereafter? So first of all, why is this important? This is Canadian sort of census data based around age. And what will draw people's attention to is just how these plots overlay, and it's stratified by male, female. The black line is the 1998 population. We've got this large spike in the 30 to 50-year-old age group. And as we get to 2018, that spike has now translocated further forward. But there's also this big white gap area from where that population was occupying that age group. So that age group now is proportionally smaller. That's the working sort of 25 to 50, 60-year-old age group, with this larger age group proportionally getting bigger relative to the younger age groups and advancing further in terms of their age. So essentially, it's saying that there's a larger group of older adults in Canada relative to our prior population distribution cohorts. And
next to the Wi-Fi, do they have to go through IT to get on our Wi-Fi?
I think so. So, okay, you know what? Why don't you?
Somebody has to mute themselves, please.
That's okay. Dan is
Stay home. So how does it usually? I thought you could just log in and you're connected.
Oh, excuse me, audience, there's somebody that's not muted, please.
Well, what about if she just uses, I wonder if
I'm
Molly's here
online.
today.
I think that's the admin office.
there we go.
Sorry about that, Dan.
Yeah, no problem. So there's aging. Older adults are important to consider. How does frailty really come into this? Frailty is the extended process of increasing vulnerability, predisposing to functional decline, and ultimately leading to death. It's seen as a loss of function and homeostasis, which is the ability to withstand illness without loss of function. So that's the key point, is you can have an illness and that's okay. But if you're losing function as a result of whatever that acute illness is or health change, then that's more concerning for transitioning into a frail status. And aging and frailty has a lot of different meanings to a lot of people, but you can kind of see this photo here kind of makes me smile, because we see some of our robust patients truly that we expect to be frail because of their age actually doing quite well. But it's important to differentiate between frailty and normal aging. And so I really like this chart because it really, for me, puts things into perspective. That aging certainly is a risk factor for frailty. And you can see that along this curve here, that over time, people will become frail, and that's sort of an expected outcome. However, if people are more sensitive or vulnerable to frailty, then they start losing function and performance faster, or their response to stressors becomes different. So in the pre-frail status, they have big changes in function with certain stressors. And then as they're frail, they have these drops in function following. So it doesn't necessarily, function is not necessarily affected following health events or external stressors. So essentially, age is a big risk factor here, but it's a more holistic sort of view of how they actually performing and measuring performance to really get a sense of what their frail status is. So how do we recognize frailty? There's a number of possible metrics and systems to use here. And so there's no real great gold standard option. The frailty index is kind of marked as one of those, but they're all applied differently depending on the context that you're working or practicing. They all have somewhat heterogeneous sort of agreeability between them, but they have reasonable performance within measure. So if you're using the same measure, it performs relatively predictably. Once you go between measures, especially if you start trying to subdivide within categories of frailty, then they somewhat break down in terms of distinguishing or differentiating different classes of frailty and matching them up. But briefly, there's a few different ways to measure frailty. One is the judgment-based method, which is sort of looking at someone and getting an overall gestalt and kind of assessing them from a broad strokes perspective. And that's what we would know perhaps as the clinical frailty scale. There's performance measure metrics. So performance measures would be grip strength or speed or get up and go. And these are objectifiable performance-based tests that use thresholds or cutoffs to dichotomize into frail or non-frail. There's physical frailty, which is different surveys of health and aging and the European Frailty Index and things like this. And these are largely reported on survey-based data. I haven't seen too many of those actually used too much in practice. The multidimensional frailty is more derived from comprehensive geriatric assessments and other measures similar to that. And then the frailty index is a 40-point scale developed by a researcher in Halifax that assigns frail, non-frail based on a proportional score of the item on the index. And there's some modified versions of the frailty index as well. Ones I find are more commonly used, particularly around here, but also in our line of work, is the frailty scale. It's this sort of 9-item pictogram with a description for each of the stages, and the description is somewhat helpful. You kind of have a gestalt based on the silhouettes, and that was the intent of the scale, I believe, but those were added post hoc once they derived these scale differentiations And once you read the subpoints, there's a little more to consider than just what their silhouette looks like, but the silhouette is a good starting place. And then beside it is the frailty index items. And you can see a lot to go through this and calculate it and emerge isn't impossible, but it would be a little more time consuming perhaps. And the clinical frailty scale has reasonable performance compared against the frailty index when trying to figure out or dichotomizing frail, non-frail status. Now, the important thing here is for the frailty index, you want to consider their function 2 weeks prior to the acute medical condition or decline in the ED. So you can't use the silhouette with the patient in front of you and say, okay, they look like an 8 because they're sick and can't get up here in the ED. You want to go back a couple of weeks and see how they were doing before whatever illness is affecting them and prompting this visit. So why is frailty important? The prevalence of frailty in older adults is different in community dwelling and admitted inpatients. So in the community, depending on where you are and the demographics of your community, it can range somewhere between 4 and 20%. But admitted inpatients, that number proportion grows to 20 to 50%, depending on your hospital and what goes on there. I'm not sure what our frail sort of demographics would be like at the regional. And as noted before, this age group is growing proportionally over the next 20 years. So as this age group grows, this proportion of people with frail status are going to grow, and these patients are more medically complex. And as we'll talk about, are going to need more care and service. So this was in the third iteration of the Canadian Study of Health and Aging. And what happened here was they looked back at the second iteration for their derivation cohort or validation cohort of their clinical frailty scale. And what they found, they just followed people assigned to each of these categories. And they found that it wasn't perhaps not surprising that as you were more frail, there was more likelihood that you would succumb to whatever additive illness that you had. And so your survival over time was inferior to your more robust counterparts. Likewise, the probability of needing institutional care or higher level care, special care, increased as your frail status escalated. So I don't know that there was much surprise here, but it helped illustrate the point that these patients are at more risk of death and more risk of requiring more complex care needs. Interestingly, the age groups for these different frail scales were pretty similar. The age group for the 1 to 3 average was 88, and the range from all 3 cohorts was 88 to 80. So these are similar aged people with different frailty scales, stratified or followed by for up to 5 years, and see what happened to them. Now, this is where things get interesting for emergency care. If we take frail patients and look at them compared to their non-frail counterparts, when they suffer things like ground level falls, they have an interesting discharge destination. So this study is somewhat limited in it's a registry study where the researchers went back and looked at patients that were admitted, did a chart review to assign a frail, non-frail status based on a score that's not commonly used. One limitation, I think, here with this large proportion that was sent to the skilled nursing facility is that they didn't know their admission source. So is this truly reflective of a change in level of care needs? It's hard to say, but it was different than their non-frail discharge destination proportion. So it would suggest perhaps a more likely increased care requirement. There's a 3% index mortality for ground level falls of frail patients within 30 days. And then a 14% readmission rate, which is significantly higher than their non-frail counterparts. And their different diagnoses were sort of interesting in that it wasn't related to pain or otherwise. Some of the reasons that they came back to hospital were somewhat more distant within 30 days. They had a readmission mortality of 15%, which was significantly different from their non-frail counterparts as well. And then this study did a subgroup analysis. However, their numbers were harder to follow, but they would say that the frail patients were more likely to have a longer length of stay as well. So for something like a low mechanism ground level fall. When we look at all comers to the ED, greater than 75 that we think are suitable for discharge, gait speed alone is an independent risk factor for both functional decline at 1 month and a 1 month presentation rate, return rate. And so the authors of this study found that there was a dose response for probability of functional decline related to gait speed. And they made a cutoff of gait speed of frail around 0.8 meters per second, which equates to the ability to travel 5 meters in 6 seconds, which is interesting because I don't know that I've ever timed anybody in the emergency department to look at how quickly they're moving. But if they took greater than 6 seconds to travel 5 meters, they had a significantly higher likelihood of functional decline and requiring more care needs at 1 month. But they also had a significantly higher rate of return to the ED for any presentation, which was somewhat interesting when considering sending people home for whatever reason they were in the ED. If we consider trauma, frailty has an interesting association. Now, this is a retrospective registry study of a single center in England. It included 26,000 patients, and this center has been tracking frail status at triage for patients starting in 2016. So that's accompanied in their registry that they're able to pull from. And these were all-comer ED presentations, not trauma. Sorry, this was just all-comer ED presentations stratified by frail status. The average age of these groups were around 75 for the 1 to 3, and the eldest age group was 84 in the level 6 frail status. And as you can see, similar to what Rockwood found in the Canadian study of health and aging, your mortality increased with your frailty status, but your probability of readmission and return to hospital is on the right panel here. And your probability of coming back to hospital also increased. Now, they do mention that there's a somewhat lower probability of return to hospital in CFS 9 and 7 and 8. They feel that there's a competing interest here because there's a higher degree of mortality. So these numbers may not necessarily reflect the complexity of care because some of those patients died and didn't come back to hospital or never left. Furthermore, if you subdivide, and these authors did a subgroup analysis, found that as frailty status goes up, length of stay also elongates. So inpatients have more complex care needs, have longer stays, and if they leave, are more likely to come back to hospital. Now, you get a similar curve if you stratify people by frail status that have suffered trauma. So this is a multi-center observational study in England. It's a registry study using trauma registries. 16,000 patients were included. The mechanism for trauma was a fall less than 2 meters for 78% of patients, and a fall greater than 2 meters for 10%. MBC was the next largest age group. So the majority of the trauma in these patients was actually fairly low level mechanism. And these plots look very similar to all of our other plots that in groups that have similar ages, around the 80-year-old age mark, but it's patients older than 65 included. As you're more frail, your probability of survival is affected. Secondary analysis of this group showed an increased association with longer length of stay, inpatient complications, and pre-injury frailty was more closely related to mortality than age alone. So, why is it important to identify frailty? I think from some of this evidence and some of these data, it's important to talk about because age is not a great predictor of how someone's going to do in hospital. Those frailty status 1, 2s, and 3s tend to do quite a bit better for their age-matched, more frail patients. So there's there's limited application for using it to guide treatment recommendations, but it can be quantified, followed over time. It has high degree of association with adverse outcomes or lengths of stays, slow recovery rates, increased requirement for care needs down the road. And it's actually pretty good at identifying people that might actually do well in hospital or have an acute illness. If someone's a frailty status 1, then they have a more reasonable chance of, recovering from this and retaining their function. What does frailty look like in the emergency department? I kind of picture this as something that we can break down into two things. We can look at transitions from robust, non-frail to risk of pre-frailty or frailty. And this is in looking for some of the high-risk features. And so that's new deliriums or dementia that's escalating or changing functional status over time. We can look at recurrent admissions or increased admission rate over time, or people presenting with symptoms that suggest increased sensitivity to medications. So that person that's now got orthostatic hypotension, what their meds haven't changed for a long time. And so all these are risk factors of transitions from non-frail to frail. We can consider using the clinical frailty scale, and I would advocate that it would be helpful if we started to, because if we start documenting in a way that's retrievable, particularly electronically, this is easy access information to go back and look at. It's not especially difficult to assign a clinical frailty scale status. There's good studies to suggest that multiple different providers of different roles can be trained to do it accurately, so long as it's sort of done properly and you look back a couple of weeks to see how those patients were doing. And another thing that we can do is add objective testing. And so can we start adding gait speed on our ambulation or walk tests? It wouldn't be too difficult to put a couple of pieces of tape on the floor in acute for 5 meters and find out how quickly people are walking. I see that as a particular application when you're a bit on the fence about, is this person able to go home? I'm not quite sure. I have a feeling that they might be a failed discharge, or they live alone, but they want to go home. And I'm looking for evidence to say that I think that this is good, or perhaps they're not going to do well at home. This can be an adjunct to some of that conversation. But ultimately, if we are gathering this information and using the same language, it's going to be more helpful, I think, in talking to our consultant colleagues to say, I think that this person needs to stay in hospital because they've suffered a ground level fall. They have a clinical frailty status of 7, which would predict a longer length of stay and increased care requirement, given what they were at home, and their care requirement at home may not even be adequate given their level of performance. And so I think it just cleans up our language and helps converse and sort of anticipate how patients are going to respond to some of these changes. And so overall, I think that frailty is an increasingly important syndrome, particularly because our resource ability for caring for multiple complex patients that particularly have a higher level of care requirement, one that we're not able to currently meet with our current demographic. And as this demographic continues to grow, I think it's going to become an increasing problem. It has significant clinical associations with mortality, morbidity, level of care, level of services, length of stay, complications, and adverse events. And I think it's helpful in discussing frailty to facilitate goals of care conversations or planning for care, because having some of this language may help converse with patients about what their expectations of admission are, or what their expectations of aggressive, invasive medical treatment versus, changing their care plans or figuring out what their priorities are. So I think it's just more information to have some of these more complicated conversations. So that, I'd like to open it up to any questions, comments, or suggestions.